So when it comes to syncope, people need to understand that there's a difference between dizziness and syncope. Dizziness would be, the medical term would be disequilibrium, okay? Dizziness and lightheadedness are not necessarily the same thing. If you get dizzy, you basically have a sensation that, sorry, the dog is being really annoying. So what I was saying is, when it comes to syncope and cases like where you have people that come into the hospital because they passed out, or not necessarily because they passed out, but just because they became lightheaded, or what's called pre-syncope or near syncope, that is semiotically different than dizziness, which the medical term for that is disequilibrium, which is different still than something like vertigo. Okay, if you're dizzy, okay, you're basically not in a state of passing out. You're in a state of, feeling like, not necessarily that you're unsteady. It's not really lightheadedness, okay? The reason that's important is because syncope is caused by really only one thing, and that's hypoperfusion of the brain. Okay, well, I guess it can also be, there can be brainstem hypoperfusion too. Like if you have something called vertebrobasilar insufficiency. But syncope is very important for internists and family medicine doctors who do hospital medicine, because it's one of those things that the majority of the time it's not really an issue, but when it is potentially an issue or there's a high-risk situation, those high-risk situations have to be identified. And really the only way to identify them in most cases is just through history taking and actually talking to patients. So the first thing to understand, like I said, is syncope and basically lightheadedness is totally different than dizziness, which is also different than vertigo, okay? And I won't even talk about dizziness and vertigo. I'll just limit this to syncope. So syncope, there are three main causes of it. The first cause is what's known as neurally mediated syncope, which is also sometimes referred to as vasovagal syncope, although vasovagal syncope is technically just one form of neurally mediated syncope. Neurally mediated syncope is where you have usually some kind of identifiable trigger that leads to some type of cardiovascular reflex. Vasovagal reflex is one example, and you get a vasodepressor or cardioinhibitory effect as a result of that stimulus. There's a huge psychological component in most cases, which is why it's called neurally mediated. And this is the most common cause of syncope. Neurally mediated syncope is not typically dangerous. In fact, if we find out something is neurally mediated syncope, that's usually a very good prognostic sign. That's a sign that someone's not going to just collapse and die out of nowhere. Okay, so that's the first category, is neurally mediated, also called reflex, also called neurocardiogenic syncope. When you call it neurocardiogenic syncope, though, that kind of can get people confused, particularly MD students and even some residents, because cardiogenic syncope is a totally different category. So calling something neurocardiogenic can kind of, promote confusion between those issues. So that's the first category, neurally mediated syncope. Second category, as I was just saying, would be cardiogenic syncope. Okay, cardiogenic syncope is where you have structural or functional problems with the heart that result in usually paroxysmal decreases in cardiac output. This is most commonly due to some kind of electrical problem with the heart, in other words, an arrhythmia. But not all the time. Okay, there can be structural issues, but this is the subtype of syncope that you need to be very concerned and vigilant about. Figuring out if the episode is possibly cardiogenic, because people who experience cardiogenic syncope have a high risk of sudden cardiac death, unless the appropriate intervention is obtained to, prevent that, whether that be an ICD or some type of, electrophysiologic intervention, ablations, things like that. So that's the high risk category of syncope. That's what we put people in the hospital after a syncopal event for, is to put them on telemetry, to get an echocardiogram to look at the structural integrity of their heart. That's the reason why syncopal patients are admitted, is to rule out a cardiogenic cause of syncope. Okay, the third major category is what's called orthostatic syncope. Orthostatic syncope is where you have I guess the way I'll explain it, it's a fixed reduction in peripheral vascular resistance, or like a venous return problem. Basically, it's where you have postural related lightheadedness, or you pass out due to postural changes, most commonly going from laying to standing. It's also a side effect of many drugs, particularly antihypertensive drugs, which are also, some of the most commonly used drugs in elderly people who are already at risk for orthostatic syncope. So, having said that, in the hospital setting, and for people who are admitted to the hospital for syncope, orthostatic syncope, as a result of medications, is probably the most common cause of syncope, especially in elderly patients. It is the most common cause of syncope. Orthostatic syncope is not the same thing as orthostatic hypotension, although orthostatic hypotension can cause orthostatic syncope. But as I explain to med students when I'm teaching them, is that definitions and things like that are very, very important. You need to have precision in understanding different disease processes and diagnoses, so that you don't confuse the phenomenon of orthostatic hypotension with basically the semiology of what syncope and lightheadedness is. Orthostatic hypotension there's a definition. It's typically when you go from laying to standing, you have a decrease in your diastolic and or systolic blood pressure a certain amount. Diastolic, it would be, I think, greater than or equal to 20. That is to say, when you go from laying, your blood pressure, for example, is, let's say, 120 over 80. You stand up, it goes to 110 over 60 or something like that. That would be considered orthostatic hypotension. Now, just because you have orthostatic hypotension does not mean that you will become syncopal. It's really, so that's why I say you don't want to confuse those two issues, okay? The best way, as I was just explaining, to test to see if you have potentially a cause of orthostatic syncope is, number one, are you on any causative medications, right? There's certain medications that are very commonly associated with causing orthostatic syncope. And like I said, antihypertensive agents being probably the most common, but there are other drugs that do that as well, even ones that are not, typically thought as blood pressure affecting drugs. The way you test someone for that is you lay them supine, completely flat, for 5 minutes. You check their blood pressure you have them go from the laying position to the upright position. You do not go from, a lot of times nurses, when you ask them to get orthostatic vital signs, what they'll do is they'll lay a patient down, check their blood pressure, have them sit, check their blood pressure, then have them stand. That's not how you want to test for orthostatic hypotension. The way you want to test for it is completely flat for 5 minutes, take a blood pressure, stand up, take blood pressure immediately upon standing, have them stand there for 5 minutes, take another blood pressure. So why do you not go from laying to sitting? Well, because, if you go from the totally supine position to a semi-recumbent position, you're giving your body and brain time to catch up and potentially, compensate. So you don't want to give them that chance. You want to really stress their ability to compensate to gravity. So you go from completely flat to completely standing. And this is how the American Academy of Neurology recommends testing for orthostatic hypotension. Okay. So those are the three categories: neurally mediated syncope, cardiogenic syncope, orthostatic syncope. Neurally mediated syncope, orthostatic syncope are typically not dangerous, typically, right? In the case of orthostatic syncope, because oftentimes it involves elderly patients who are very frail, prone to things like hip fractures, and just falling in general. Yeah, orthostatic syncope can be very dangerous. So, but in that case, usually you can identify a causative medication and either reduce the dose or stop it, and then potentially the problem is fully solved. But those people typically are not, if they're admitted to the hospital, it's usually a one-night thing. We make sure their heart is fine because, again, the category that we're concerned about is cardiogenic syncope. Cardiogenic syncope is something that can kill you. It's something you need a doctor for to figure out if that's what's going on, and you need appropriate interventions to prevent yourself from basically experiencing sudden cardiac death. When you're talking about, I think I touched upon this, but most cases of syncope that you encounter as an ER doctor or as a hospitalist, it's incredibly important to get a good history, because the history will tell you oftentimes the type of syncope that this person is experiencing. Okay? If you have a patient that comes in, basically says, you want to get what's called the semiology of the event. Semiology is a word that is often used by neurologists to describe the characteristics of seizure-like episodes. Okay? And what it means basically is what happened specifically? What were you doing before it happened? What happened during the event? Or oftentimes we use the term spell, okay? So what happened before the spell? What happened during the spell? What happened after the spell, okay? And when you're talking about seizures, you're talking about, what triggered it? What did you feel beforehand? There are certain types of, prodromes or prodromal symptoms that you can have that signal the onset of a seizure, and there are certain symptoms that you may have after the event that suggest that a seizure is actually what you experience. That's called a post-ictal state. Okay, syncope is a very similar thing. You need the semiology. So what happened before? In the case of cardiogenic syncope, what we're really concerned about is someone who passed out without any kind of warning. So in other words, a total absence of what's called a prodrome, meaning they're going about their day, they feel totally normal, and they collapse like that. People who have neurally mediated or reflex or, vasovagal syncope, typically these people get very dizzy, they get lightheaded, they get oftentimes nauseous, they get profoundly sweaty. If you ever come close to passing out while having your blood taken, for example, there's a very classic example of neurally mediated syncope. So in the case of taking a history, if someone tells you, I was just feeling very sick, nauseous to my stomach, and then I nearly passed out, that's usually a good sign that it's not cardiogenic syncope. It doesn't completely rule it out, But if you think about the underlying physiology of what has to happen if your heart is the cause of you passing out, you can think of it like this. If your cardiac output suddenly drops to zero, what's going to happen? You're going to go from having adequate blood flow to the brain, which is why you feel totally normal, to you pass out. Okay? So that's a very worrisome sign on a history, is if you have no prodrome. The other thing that's important to note when you're taking a history is did the episode occur during strenuous physical activity? Not after strenuous physical activity, but during, especially like at your peak of physical activity. So in other words, someone who collapses while running a marathon, someone who collapses while running on the treadmill. These are all very concerning. This would be a concerning historical feature for cardiogenic syncope. Okay? If it happens after exertion, that can sometimes be, neurally mediated. That doesn't necessarily mean it's cardiogenic. But if it happens like in the middle of a soccer game, particularly in a young patient, okay, because you think young people, middle school age kid is out, on the football field or whatever and collapses suddenly, you would think that that's really concerning because this is a young person with, who's otherwise completely healthy. Chances are, if it's an older patient and they had a pretty significant structural lesion or an electrical problem, like it would manifest earlier in life. Like they wouldn't just go like 30, 40, 50 years without experiencing any kind of these spells before. That makes it like a little bit less likely. That doesn't mean it can't happen. Anytime you have syncope during physical exertion, that's a concern. Okay, but particularly in a young person, that's very concerning. If syncope occurs in the supine position, like when you're laying down, that's also concerning, right? Because then there's no postural or gravity component. So that almost completely rules out an orthostatic cause of syncope, right? And that is concerning. That's concerning for cardiogenic syncope. And then, obviously, if you have someone who has pre-existing heart disease, specifically heart disease that would predispose you to either structural or electrical problems with your heart, you have like heart failure with reduced ejection fraction. Low ejection fraction is associated with sudden cardiac death, which is why a lot of those patients get ICDs. If you have coronary artery disease, you have some kind of valve problem, or if you have a known arrhythmia, okay, those are all things that, you need to be aware of when you're taking the history of a patient who's syncopized. The other thing is personal history, but also family history. So if you have a family history of someone who's experienced sudden cardiac death, especially, that's also concerning. Now, you do have to do some clever history taking and question asking sometimes, because what has happened and what I have encountered is that sometimes you will question a patient who's syncopized about their family history. They'll say they have no history in their family of sudden cardiac death, but yeah, by the way, their brother when he was 9 years old was swimming in a lake and he was a really good swimmer. But he drowned within 2 feet of the shoreline, okay? And everybody's just assumed he just drowned, but he was a good swimmer. Did he have like some kind of cardiac event that caused him to syncopize and then he drowned, or did he just drown? So you have to be kind of clever. So what I often ask is, do you have any history of anyone in your immediate family who was a good swimmer who drowned unexpectedly or who died unexpectedly? That's important to know too. I think that's all I want to say about the history. Like the history, like I said, is when you're in the hospital setting, the history of a patient who is syncopized is very heavily focused on determining the etiology of the syncope. If you can determine the etiology and determine that it's a benign etiology, that's a patient that can be safely managed in the outpatient setting, okay? If you have a patient that is potentially concerning for a cardiogenic episode, well, then that's a patient that potentially needs to be admitted to the hospital, put on a telemetry monitor, and have a detailed cardiac investigation. Typically, and I'll get to that, I guess, in a minute, because we're just talking about the history. I guess another thing I want to mention about the history is this. So, in your documentation for medical legal purposes, what I will often write in my notes is that if I take a history of someone and I think that their history is most consistent with a non-cardiac etiology, and especially if we're going to discharge the patient, what I say is history is significant for lack of features which suggest cardiac syncope. The spell, and I wrote it down here, so the spell occurred following a prodrome, most consistent with neurally mediated syncope, did not occur while the patient was supine, did not occur with physical injury, did not occur during exertion. There was a definitive hangover effect or a prolonged return to their baseline mental status, which is so that's another thing I need to touch upon also with the cardiogenic syncope, because I failed to mention this. One other concerning hallmark of the history of a patient with cardiogenic syncope is oftentimes after the spell, they will regain consciousness and not have any kind of, hangover effect, post-ictal state, whatever term you want to apply to it. They feel relatively normal. And this should make sense physiologically, because you imagine if your heart stops and it's able to restart itself, to put it in the most lay terms that I can put it in, there's a lot of adrenaline associated with that process. So typically those patients collapse suddenly, wake up suddenly, if they survive the event, right? So the absence of a postdrome, the absence of a hangover effect, that is also very concerning, or one of the historical features you should be concerned about with regards to cardiogenic syncope. Okay, so like I said, what I do when I document this is I document the absence of all these key historical features. Didn't happen when the patient was laying down, didn't happen during physical exertion. They had a very clear hangover effect. They had a very clear prodromal symptoms like nausea, sweating, things like that. And they have no known history of cardiac disease, and I'll especially cite if they've had recent echocardiograms or they've had, electrophysiology studies, things like that. That needs to be cited in your documentation to support the fact that you have taken a detailed history and have determined that this is a patient who is extraordinarily unlikely to have a cardiogenic etiology of their event. And that way, you can protect yourself just from a legal standpoint. In terms of the exam of a patient who's had a syncopal episode, my generation of physicians were not, any physician that's under the age of 60 years old, we are not very good at performing a classical physical exam. That's just there have been studies showing this. It's just, our physical exam skills, as the technology available to us has gone up, our physical exam skills have gone down. The good thing is with syncope, the main, thing, you do a cardiac exam, listen for any obvious murmurs. If you have one, obviously that's something you may want to investigate further. In the case of syncope, I also look at in their mouth and see if they have lateral tongue lacerations. Sometimes it's rare, but sometimes you can confuse syncopal events with seizures. Okay, so one sign that someone's had a seizure is, they often they bite their tongue, right? So that's something I check for. The other important thing is just to get orthostatic vital signs. And like I was saying earlier, the way that you check orthostatic vital signs is you have a patient lay completely flat, with their head flat, okay? You don't prop them up on pillows. You have them lay completely supine. After they're done, after 5 minutes, You take their blood pressure, take their pulse, and then you have them stand up. Immediately after they stand up, you check another blood pressure. You have them stand there for 5 minutes, you check another blood pressure. So why do you do it immediately upon standing, and why do you do it, 5 minutes later? Well, some people can have delayed orthostatic hypotension, meaning they stand up, they don't feel dizzy, and their blood pressure doesn't actually drop until they've been, in a standing position, exposed to gravity for, a certain short period of time. So you want to make sure that if you miss the immediate hypotensive effect, you don't miss the delayed one. So those are the steps. Flat for 5 minutes, take blood pressure. Stand up, immediately take blood pressure. After 5 minutes, take blood pressure. Okay, there's no sitting stage to that at all. And those are the American Academy of Neurology recommendations for how to take orthostatic vital signs. I think I kind of talked about the differential diagnosis. There is obviously an age component to all this, and so, like I said, it's one of those things where if you have a young person in the emergency department who was taken in by ambulance after passing out at their football game, and they're sitting there, they feel totally fine, and they had no kind of post-drome, that's very concerning. As opposed to if you have a 90-year-old lady at the nursing home who's on 4 different blood pressure medicines, and her primary care doctor just added another one last week, and she was sitting in her, rocking chair. The nurse went and got her up to help her go to the bathroom, and she passed out or nearly passed out. Obviously, just sometimes you can figure it out pretty much just based on the history that you get from the triage nurse, right? And that can obviously be a helpful thing. So age is definitely a big factor in all this. I did say neurally mediated syncope is very often accompanied by a prodrome, especially nausea, sweating, things like that. So that's obviously something you need to determine. And if you have that, that's typically a good sign that it's a neurally mediated event. It's important to note you can have neurally mediated syncope in the sitting position. It's rare to have it in the supine position, though. So what I would say is, just because someone syncopizes while they're sitting doesn't mean it's not neurally mediated. If it happens while they're laying flat, though, that's concerning. Okay, so that should not be ignored. And no matter what the background circumstances are, no matter what their age, if it's happening while they're laying flat, that's concerning. Okay. I did make a note about long QT syndrome. So long QT syndrome can be congenital or acquired. Obviously, if you have a predisposition to dysrhythmias, and having long QT syndrome obviously predisposes you to dysrhythmia. That's obviously important to note about. The thing that is really crucial with that is look at people's medications in detail, okay? Because there are a lot of QT prolonging medications, and there are some medications that we use very, very commonly that have pretty profound QT prolonging effects. The one that comes to mind most often, the one I've seen most often, is a drug called Celexa or citalopram. So that would be an SSRI antidepressant drug commonly used for generalized anxiety disorder, panic disorder. It's very, very, very widely used, okay? At one point in time, the max dose of Celexa was 40 milligrams. At 40 milligrams, we know that Celexa can cause pretty profound prolongation of the QT interval, which is why now oftentimes the guidelines are recommending a maximum dose of 20 milligrams. Now, I have personally seen patients who are on citalopram go from a normal QT interval to one that's almost 600. Then this would be a corrected QTC interval. That's really bad, okay? And if you see that you need to do some medication management and reduce some of the polypharmacy that causes that. The most up-to-date resource to find a list of drugs, or to determine if a drug a patient's on has QT prolonging effects, is a website called crediblemeds.org. Again, that's crediblemeds.org. And that is, I think, run by a group of cardiologists who, stay very up to date on the pharmacology literature, and they're constantly just updating the list of drugs that are on that list. So that's another thing, is take a detailed, medication history. Oftentimes we get, I'm going to talk about just the workup and management separately, but oftentimes we get EKGs in people who've had syncopal events, even if it's obvious, just because the EKG machine's sitting right there in the ER and it's just easy to access. So beyond QT, problems, what else do you look for on an EKG? Okay. The obvious things are like really prolonged pauses, particularly in someone who's awake. If they're having pauses of, they're having heart rates under 40 beats a minute, or pauses lasting longer than 3 seconds while awake, again, they have some kind of heart block, particularly like a Mobitz 2, or a complete AV block. Obviously I said long, short QT intervals. Obviously there's, you need to look out for things like a Brugada sign. So a Brugada sign would be a coved ST segment elevation that's greater than 2 millimeters in more than one lead of V1 through V3, followed by a negative T wave. So that's called a Brugada sign. In patients with a totally normal EKG, that is a fairly strong indicator that the episode was not cardiogenic. But it's not a 100% thing, because people can have normal EKG and a normal echo. And there are rare conditions like catecholaminergic ventricular tachycardia. Those things will only, manifest in paroxysms, and there won't be any structural signs why there's nothing on an echo, and oftentimes their EKG is going to be totally normal. So that's something that can only be teased out in an electrophysiologic study. And so here's where a lot of the science and algorithms and rules don't necessarily apply. Is if you have a very young person with all of the historical hallmarks of a cardiogenic episode, who you then have normal EKG, normal telemetry for 24 hours, and a totally normal echocardiogram, but yet you still have all these historical features that suggest it's a cardiogenic episode, and they're in a demographic where you'd be most concerned about it, particularly a young person. So in that case, that's where you would get an electrophysiologist involved. That's where you do things like EP studies. That's where you would do these more really super expensive, super advanced tests to really ensure that you're not dealing with cardiogenic syncope. So even though we often say people with totally normal EKGs, people with totally normal echoes rules out cardiogenic syncope, that's not a 100% rule. And if that is your 100% rule, you're potentially you're gonna miss some catastrophic underlying paroxysmal electrical problem. And the example that I use is something called catecholaminergic polymorphic VT. Okay. So I think that's all I want to say about that. In terms of the workup of undifferentiated syncope, we said, EKG and a simple transthoracic echocardiogram. Okay. If you have a patient with no historical concern for cardiogenic syncope, and you have no detected EKG or echo abnormalities, that's pretty much where you'd stop. That's pretty much where you'd say this is a neurally mediated episode, potentially an orthostatic episode. If it's the former, okay, leave it alone. If it's the latter, then you look for the cause, usually a medication, get rid of the medication, and that often solves the issue. If you have a patient, like I said, with historical concern for cardiogenic syncope, but a lot of their workup is normal, that's when you may, decide to do things like loop recorder monitoring, or even just getting an electrophysiologist involved. There is a type of neurally mediated syncope called carotid sinus syndrome. And the test for that is a tilt table test. And it's not an amazing test. Has a very high rate of false positives. You can even do things like carotid sinus massage. But I still think even in that case, you're oftentimes going to proceed with an EP study or, event monitoring, something like that. If you have a patient with cardiac disease or obviously some kind of rhythm abnormality that's evident on an EKG, and particularly if they have an echo showing their ejection fractions under 35%, that's a patient that you want to get a cardiologist involved. Oftentimes those patients need an implantable cardioverter defibrillator, what's called an ICD. Patients with coronary artery disease, even with normal echoes, especially if they have left ventricular hypertrophy, and also if they have conduction abnormalities on their EKG, that's often a patient that will be referred to cardiology. Same thing with valvular disease, cardiology referral. If you have a bradyarrhythmia or, long pauses, that's a person that typically, gets a pacemaker placed. One thing that we often do, I don't know if we often do it, at least I often do it, is patients with orthostatic hypotension with neurodegenerative disease, meaning mild cognitive impairment, something that's not necessarily diagnosed as they have, a type of dementia, but obviously they're impaired. Oftentimes I'll check a vitamin B12 level. Okay. The tests that you want to avoid in the workup of isolated syncope is brain imaging. Why? Okay, as I said, if you have a syncopal event, that's typically caused by global cerebral hypoperfusion. Okay, so doing things like looking at the structural integrity of the brain and even doing things like carotid duplex ultrasound are really low yield tests. Why? Well, if you're going to have global hypoperfusion of the brain, in order for your carotid arteries to be the cause of that, you would have to have a simultaneous near 100% blockage of both arteries that resolves on its own. I mean, it just doesn't happen. So therefore, this common practice of checking, carotid ultrasounds on people with isolated syncope is not a high yield exam. It's a very low yield test, and it's not one that you should perform typically if you're just talking about isolated syncope. Tilt table testing. It's been a long time since I've ordered tilt table testing. I want to say we did it very commonly at the VA where I was a resident. And I'm not really sure why we did it. Maybe just because it was easily accessible. We had cardiology fellows who could do it, It's just one of those procedures that is not really done very commonly. The thing to know about tilt table testing, as I already mentioned, very high degree of false negatives. It can be used to diagnose a neurally mediated syncope. In other words, if the test positive, that strongly suggests you have a neurally mediated syncope. Sometimes it's carotid sinus syndrome, some vasovagal syndrome, whatever it may be. But it doesn't give you the specific etiology, I guess is what I'm saying. So the utility of the tilt table test is highest in people with at least an intermediate pre-test probability for neurally mediated syncope. In other words, if it's a patient that you think doesn't have neurally mediated syncope, it's not a test that you should do, because the test is just not very good. It's more likely to be misleading in cases where you're not suspecting it than to be helpful. Okay. The way you're supposed to do a carotid sinus massage, if this is something you want to do, is you usually have the patient in a, first of all, you massage the right carotid artery, and you do it in the supine and upright position for 5 seconds, then repeat it on the left side. You have to have heart rate monitoring while you do this, and usually you have to have blood pressure monitoring while you do this. So it's not simply massage their carotid artery and see if they pass out. No, you want to see what their heart rate and blood pressure response is to the stimulus, okay? And obviously you do this in the semi-recumbent or supine position, because if they pass out, it's safer for them to already be laying down, right? You should not do carotid sinus massage on people with known significant carotid stenosis. And there's also a contraindication for people who've had MIs within the last 3 months. So those would be the exceptions to that. I think that's all I want to say about the workup and diagnosis. The two main things you do is EKG, echo. If those are normal, that typically helps you out. If you still have concerning historical features despite those tests being normal in the right patient, then you may do some of these more advanced tests. But the EKG and the echo, that's like 90% going to get you there. MRIs, CTs of the brain, carotid sinus imaging, even, CT, angio, head and neck angiogram, things like that, not useful in isolated syncope, typically should not be done. And again, the reason they shouldn't be done is, as I explained, in order to have a syncopal event, you really have to have global, blood flow reduction to the entire brain, and to have that just from carotid lesions is pretty rare. Let's see what time we got, 9:15. So management and treatment. In the case of neurally mediated syncope, often the only treatment is just reassurance, right? Maybe avoidance of whatever triggers, because oftentimes, the classic example, someone getting their blood drawn, pass out. I still sometimes do that, embarrassingly, even though I'm a physician. I don't know what it is. It's not the sight of blood that bothers me by any means. It's just, for some reason, just having my blood drawn, being poked and stuff, it oftentimes provokes that kind of vasovagal reaction in myself personally. So there are a lot of people that are like that. Okay, so what we say is typically neurally mediated syncope. It's just a matter of reassurance. You can teach patients who are encountering their triggers to do things like, hand grip or leg crossing, things like that, what are called isometric counter pressure maneuvers. So this helps, raise cardiac output in advance of or during experience of whatever the trigger is. But usually these cases are, self-limited, and it ends up being okay. In the case of orthostatic syncope, like I said, the most common cause are medications, so you remove the offending medications or reduce the dose or whatever. Ideally, you would remove the offending medication and then, do the orthostatic vital signs again. And they come in and it's, really abnormal. You stop the medication for 24 hours, do it again, and then it's normal. Well, then typically you found your cause. So in that case, removing the offending medication. There are cases where you have orthostatic syncope in the absence of medications, or in the presence of medications that can't really be removed for a variety of reasons, or at least shouldn't be. One case is like beta blockers in patients with heart failure. Sometimes, it's not really a good idea to remove the beta blocker. So in that case, you have to deal with it. And there can be other situations. In that case, there are medications you can give to help. One is fludrocortisone. Another is a drug called midodrine. And then another is a drug called pyridostigmine, which I've never prescribed. But those are the kind of the drugs that you can use in refractory cases of orthostatic syncope. If you have orthostatic syncope that's due to primary autonomic failure, the classic example of this would be Parkinson's disease. Okay, these patients have autonomic failure, and so they have difficulty. Again, in the absence of drug causes, they have difficulty compensating posturally just by virtue of their disease process. In that specific case, you can use a drug called droxidopa. Again, this is not a drug that I prescribe, but it's a drug you take 3 times a day, and typically it will give a positive symptomatic response. It's important in patients with Parkinson's to realize that if they're also on carbidopa, that actually reduces the effectiveness of droxidopa. So just you have to be aware of it. Oftentimes you may need a higher dose or whatever the case may be, but there is an interaction there, and it's one that decreases the effectiveness of the medication. Any patient that constantly experiences orthostatic syncope and orthostatic hypotension needs to be coached to elevate the head of their bed, prop themselves up on pillows, give themselves time to not just go from laying to standing. They need time to more slowly get up and compensate, or have people there that can help them. Particularly, you have nursing home patients, that's the case. Sometimes things like caffeine can help. Sometimes it's not helpful and even, can cause issues. But for some people, caffeine can help. One thing you have to be very cautious of in patients with orthostatic hypotension, particularly if they're on medications to counteract the orthostatic hypotension, you need to make sure that they don't have supine hypertension. So a lot of these drugs will raise your blood pressure significantly. And so what you don't want to happen is for the patients to be under the chemical effects of the drug 24/7, even when they're laying flat and sleeping, because you can cause really profound blood pressure elevations in those patients if you do that. So you just need to be aware of, this is a drug you want to prescribe during times of the day when they're actually active, when this could actually, be a problem, and not necessarily when they're sleeping or supine, things like that. That is really a broad stroke discussion of orthostatic syncope and its treatment and management. For cardiogenic syncope, a lot of those patients who come in through the emergency department will be admitted to the hospital. That's just the reality. Unless you can get an echocardiogram the exact same day, and if you're for some reason don't think that a telemetry monitoring will be very helpful, oftentimes those patients are going to at least be admitted for observation, meaning typically a one-night overnight stay, and we'll monitor their telemetry for a period of 12, 24 hours, whatever the case may be. And that'll give us more data, like maybe is this person, telemetry monitoring, the drawbacks of it is the same drawbacks that you get with things like Holter monitors. You only get a very small snapshot in time of what their electricity is doing. And so if they're a type of person that has very rare episodes, chances are 24, 48 hours of monitoring not really going to, you're not really going to find an etiology in most cases with just that short of a period of time if their spells are very rare. Obviously, the thing that you get the most out of telemetry is when you have patients with prolonged pauses. You have patients with AV blocks, particularly, like I said, second-degree Mobitz type 2 or, third-degree heart blocks, or what's called complete atrioventricular blocks. Those are, and particularly having pauses greater than 3 seconds while awake, You have profound bradycardia while awake in the absence of obvious medication causes. You have alternating left and right bundle branch blocks on sometimes even the same EKG or separate EKGs. Those are patients that typically need to be referred for pacemaker placement before discharge. Okay, and I think that's kind of the where I've encountered telemetry monitoring to be the most helpful, even though we do it on every patient admitted for syncope, right? Patients with cardiomyopathy and LV function issues, those are patients that may need a defibrillator, okay? Patients with normal EF who have LV hypertrophy or coronary artery disease or anything that really in their personal medical history really raises suspicion for kind of this paroxysmal electrical episode, that's a patient where you may get an electrophysiologist involved. And then obviously this applies to young people, particularly African American patients, young patients, particularly young black men. There's a higher incidence of hypertrophic obstructive cardiomyopathy. Those patients need an ICD, right? And then obviously if you have patients with low EF, typically under 35%, maybe those values have changed recently, so we need to check the updated guidelines. But the number that I have is 35%. If it's equal or lower than 35%, typically ICD placement is the right way to go. So I think that's, again, a broad brush of the treatment and management of cardiogenic syncope. One thing that a lot of physicians, I would say the vast majority, forget to do in the ultimate what we call disposition of these patients and discharge planning. This is something neurologists never forget to do. I shouldn't say never, but almost never forget to do in the case of patients admitted for the workup of seizures. But it needs to be done by hospitalists in the dispo patients with syncope. There are driving restrictions, okay? So if you have a patient with undifferentiated syncope, even after their admission, you haven't figured out the cause, typically I tell those patients and document they should not drive for 6 months from their last spell or episode unless the cause of their syncope is identified. So I tell them and their family members, you should not drive for 6 months from your last episode. And then they obviously have follow-up. If we can figure out a cause, we can fix it, then that 6 months can be truncated. But if no cause is identified, you need to document specifically, I told this patient it is dangerous and life-threatening to themselves and others if they drive within 6 months of their last episode. Patients with vasovagal syncope who have rare episodes, I typically tell them no driving for 1 month from your last episode or spell. If they have lots of vasovagal episodes, greater than 6, I tell them you shouldn't be driving until this is under control. Now, as a hospitalist, if I have a patient with many episodes of vasovagal syncope, and let's say they've been admitted recurrently, or whether or not they've been admitted recurrently or this is just their first admission, if they give a history that they are passing out a lot, and my number is, let's say, greater than 6 episodes a year, those patients, I just tell them you shouldn't drive. My recommendation, my medical advice is you should not operate a motor vehicle or any kind of heavy machinery or work from heights, or take hot baths, go in hot tub, whatever. You shouldn't do that at all until such time as we can actually get your episodes under control. When I say we, typically it's their primary care doctor or whatever outpatient specialist, a neurologist, a cardiologist, whoever is seeing them, gerontologist, whatever. Those patients need to be told you shouldn't drive. Because if you think about it, if they're passing out a lot, clearly they shouldn't be on the road. It's going to be life disrupting for those patients but at least nobody dies if they're behind the wheel and they pass out. So I know that a lot of people balk at that, but that is what I tell patients. Do not drive. If we can't figure out the cause. Even if you have neurally mediated syncope, when we've figured that out and that's been definitively determined, but you're having lots of episodes, you need to be restricted from driving. And I tell patients that. Same thing with really any other type of syncope. Even if you have the etiology, you know what's causing it, but it's not adequately treated and they're still having spells, that's a patient, they're indefinitely restricted from driving. And you need to write that in your note and have that discussion with the patient and the family. No driving. They may be pissed off, they may be angry, and that's just one of the things as physicians that we have to, we have to give people advice that not only protects them, but protects their family members and the general public, okay? Because imagine you discharge someone from the hospital who's had 30 episodes of vasovagal syncope in the last 3 months. And they, a week later, are driving a semi-truck or even driving their regular car. They get in a car crash, a bunch of people die. Do you think there's some liability that you have there, knowing that person was in the hospital just a couple months prior and you have a documented history of 30 episodes of them passing out, and you didn't discuss anything about driving and working from heights, and something catastrophic happens? You're going to be exposed to significant liability. And there have been cases, malpractice cases, general liability cases, personal injury cases, where doctors and hospitals have been sued for patients that either killed themselves or killed other people, because they weren't given driving restrictions or whatever. I guess that's what I'd say. Patients with ICDs, I think the guidelines are like 3 months from the last spell when they shouldn't drive. But in the case of patients with ICDs, they typically are following with an outpatient cardiologist. When they get discharged from the hospital, knowing that their follow-up is going to be with a cardiologist, I tell them 3 months from their last spell, no driving. And if your cardiologist tells you something different, you can go based on what your outpatient cardiologist tells you. But at that point, it's out of my hands and in the hands of their outpatient physicians. But you need to protect yourself, and just use common sense. I think that's pretty much it with regards to syncope. I think that's pretty much it. That covers a wide range. Obviously, you can get into a great detail, especially on the workup and treatment. When is it appropriate to order things like Holter monitors? When is it appropriate to do things like loop recorders? But for the medical students and residents, especially if you're not an internal medicine resident and you're not going to be dealing with this issue regularly, the 2 key tests to know, EKG, echo, those are normal. That rules out the vast majority of cases of cardiogenic syncope, not all of them. And if the history is concerning despite those normal tests, potentially they need further workup. And if you don't know exactly the type of workup they need, that's when you need to involve a cardiologist. And then the other thing is, please stop ordering CT angiograms of the head and neck. Please stop ordering MRIs of the brain. Please stop ordering carotid duplex ultrasounds. Those tests, if you're dealing with syncope, are not useful tests. They are far more likely to lead you down the wrong path in terms of diagnosis and management. And they waste resources. They're just not helpful. So those tests don't need to be ordered for isolated syncope. Now, there can be cases where you're not sure that it's a syncopal episode, and maybe some of those tests can be, appropriate. But if it's a clear syncopal episode, those tests are low yield. And then in terms of treatment, what you need to know is, if it's a neurally mediated event, the treatment is primarily reassurance. If it's an orthostatic event, the big Key thing is make sure check their medicines, remove offending medications if they can be removed. If you have cases of orthostatic syncope in the absence of medication causes, then that's when, and especially if they're refractory, there are drugs you can use, like I said, fludrocortisone, midodrine. You need to be careful about supine hypertension with the use of those medications. And oftentimes as a hospitalist, those are not typically medications we're going to send people home with. I mean, we can do that, but that's typically an outpatient thing. So usually that's managed by an outpatient, physician. But do remember that supine hypertension can be a big problem. And supine hypertension, in the case of the treatment of orthostatic syncope, is a common question on board exams. So that's also something to keep in mind, all right, is you want to prescribe drugs for orthostatic hypotension only during the periods of time when, they're going to be in an upright position, right? So you don't want to be prescribing drugs that last even, while they're sleeping, because oftentimes, like I said, you're going to cause really significant nocturnal or supine hypertension. And it is the case that patients with orthostatic hypertension often have concomitant supine hypertension. And patients with autonomic failure are at really high risk of this. So that's another thing to keep in mind. The other thing that complicates supine hypertension is giving those patients antihypertensives will obviously make the orthostatic hypotension more severe. So these can be really complicated cases. The orthostatic syncope cases that are refractory, those can be really, really hard to treat and balance the supine hypertension and then the orthostatic hypotension, and achieving some kind of balance between those things. In the case of cardiogenic syncope, the key thing to understand about the management is that once you are pretty sure that it's a cardiogenic episode, typically that's when you're going to involve a cardiologist, and you need to know the indications for ICD placement. You need to remember, keep in mind the 35% EF number. It's a very, very key and important number. If you have an EF below 35%, typically that's an indication for placement of an ICD. And then, but beyond that, typically not really well tested. And just from a practical standpoint, oftentimes you have a cardiologist that is involved in that case, and they will help you with the management and further workup. The big thing with cardiogenic syncope that you'll encounter most commonly in the hospital setting as an internist or as a family med doctor who does hospital medicine is bradyarrhythmias, and when does someone need a pacemaker. You need to keep in the back of your head, and this is not just for patients in the hospital because of syncope, but any patient who's on telemetry, okay, if they're having pauses greater than 3 seconds while they're awake, that is also potentially an indication that the patient needs a pacemaker, okay? So pauses greater than or equal to 3 seconds, just be aware that 3-second number is very important. And then obviously heart rates that are under 40, that's also potentially a concern. So I think that's about it. Thanks for joining me today. Be back again tomorrow, and we'll get into more stuff. So thanks. Take care.